Thank you everyone for joining the Research and Innovation Conference. Our next speaker is Dr. Timothy Yan. He will talk about optimizing endoscopy procedure documentation, improves guideline and adherent care in upper GI bleeding. Dr. Yan is currently the Chief GI Fellow. He got his MD degree at NYU. Did his residency at Stanford University, and then has been doing his fellowship here in GI and hepatology, and is currently the chief fellow. So with that, Dr. Yan.
Thank you. Thanks for having me. My name is Tim Yan. I'm one of the Chief GI Fellows as well as one of the LINCS Fellows. It stands for Leaders in Informatics, Quality, and Systems. And I'll be talking about my quality improvement project today. It's a project that I did over the course of both my GI Fellowship as well as part of my LINCS Fellowship for the last couple of years or so. And the title is entitled Optimizing Endoscopy Procedure Documentation Improves Guideline Adherent Care in Upper Gastrointestinal Bleeding. So some background, many people know that upper GI bleeding is a very common indication for an inpatient EGD. And the outcomes afterwards are often dependent in part by guideline-based post-EGD care. So the aim of our quality improvement project was to optimize and standardize documentation after EGD for upper GI bleeding to improve the clinical care thereafter. This project was supported by the University of Colorado Hospital as well as the School of Medicine CEPS grant, and no disclosures otherwise. So when approaching a problem in quality improvement, in this case, being suboptimal clinical care after upper GI bleeding, often, many people will organize their thoughts and the contributing etiologies into what we call a fishbone diagram. And here, the three categories on top have to do with medical knowledge, diagnostic reasoning, and therapeutic choices. And those really, in this case, really revolved around what the guidelines say about medications and what the guidelines say about when to do a repeat endoscopy, as well as what the likelihood is that someone's going to rebleed after our endoscopy, as well as what medications they should get afterwards. That's often dictated by a specific type or severity of lesion that we see in endoscopy. Now, the bottom three categories of contributing factors are 1, materials and machines, 2, personnel and people, and 3, communication. The first one is really what I focused on, and that really has to do with a lot of the electronic medical record. So number 1, in gastroenterology, in many places, including here at Colorado, we have multiple electronic health records. We have one for clinical care, EPIC, and we have another one specifically for endoscopy. Here it's called Provation. Second, there is a decent amount of documentation burden within both of these EHRs. One, everybody's familiar with EPIC and writing notes, etc. But 2, within Provation, compared to EPIC, a lot of the way that we write reports in there is essentially a large conglomeration of drop-down menus. And so it's quite a bit of clicks to get to a fairly standard report. And second, there is no real-time documentation. We do the endoscopy, and then we have to remember exactly what happened, what we found, what we recommend. And then after we finish endoscopy, we write that report while the patient's getting recovered. The second category, personnel and people, just being in a large academic institution, there's a lot of shift handoffs between teams, whether that's between gastroenterology and primary teams, as well as between day shifts or evening shifts providers as well. And second, there are lots of multiple inpatient and outpatient providers as well. And then communication. In addition to just multidisciplinary teams, there's also variable rates of communication. One is through the electronic health record, and that includes consult notes as well as the procedure report itself. Once we sign it in probation, it actually goes and gets uploaded to the procedures kind of tab of Epic, as well as a variety of ways to communicate directly, whether that's secure messaging or page or verbal. Now, in all of these categories, in trying to decide what was the most optimal and ideal focus for an intervention, we kind of really honed in on this category of materials and machines, particularly because of the way we document. A lot of what we kind of do in terms of clinical reasoning and clinical recommendations kind of feeds into the documentation portion. And while there are a lot of other contributing factors, this serves as kind of a core kind of stopgap. To better illustrate this, you can use a diagram called swim lane diagram, where it kind of outlines how a workflow happens when there's multiple parallel kind of processes. So this first blue row really refers to the primary inpatient provider. So whether that's medicine, family medicine, the intensive care units, surgery, etc. The second row has to do with what the gastroenterology consultants do in Epic in clinical care itself. And the third has to do with the endoscopic portion of it. So first, a consultant calls in the top left a upper GI bleed consult. And then second, we evaluate the patient. Now in green, we write a consult note in the Epic EHR with a plan for EGD in this case. A second, almost simultaneously, we have to both document a pre-sedation note in Epic, as well as create a upper endoscopy case record in our endoscopy software. Then we get to perform the upper endoscopy. And let's say we find a ulcer, we treat it, and we know what we're going to recommend based on what we did and whether we think it's going to rebleed. So then we complete the endoscopy report. That automatically, once we sign it in probation, gets kind of migrated and copied into the Epic procedures tab. And then we simultaneously again have to either order a post-procedure medications if applicable, or we have to order a repeat endoscopy in Epic, as well as communicate these findings from the endoscopy report to the primary team. Now, here's where it kind of branches as well. If it's during the daytime, it's the middle of the day, we can talk to the primary provider taking care of the patients on the floor, for example, and they can enact those recommendations. However, it's after hours, it's often someone else who's covering, and they may enact those recommendations if they're more urgent, and then hand those off the next day. Because and then in focusing on that documentation portion, if you saw in the previous report where everything kind of funnels in, to that, endoscopy report, we use national guidelines to build optimized etiology and severity specific note templates at our hospital here. I led a 10-minute training session, kind of part of like large meetings, grand rounds for 39 gastroenterology attendings at the time and 15 fellows. And to kind of delve into a little bit more without getting too much of the nitty-gritty, this is the way we design these kind of 5 endoscopy templates. So first, we had these 5 templates based on the etiology or severity of the culprit lesion causing the bleeding. So that would be high-risk non-variceal bleeding, like ulcers, low-risk non-variceal bleeding, so ulcers that are unlikely to bleed again, portal hypertension related bleeds, such as variceal bleeds, 4th, non-variceal portal hypertensive gastropathy bleeds, and then the last one is what we call obscure overt bleeding, where we don't find a reason. The second, we thought that it was important to outline in a report what disposition that patient had afterwards, whether they remained in the ICU or whether they were okay to go down to the floor. And then what diet advancement was important. So whether they could remain, whether they should remain NPO or if they could advance their diet and when. Third, the medications were a very, very big component. So in the vast majority of bleeds that are not related to varices, what do we do with the PPIs? And if they're, they have portal hypertension, what should you do with the octreotide? Should we give them antibiotics? How much? And then some anti-thrombotic guidance as well. And then finally, kind of guidance on what happens if this patient bleeds again. Do you call us, the GI consultants? Do you call the radiologist? Do you call surgery? And then the last thing, really more for the gastroenterologist, is does this patient need another endoscopy or colonoscopy or some other procedure to follow up thereafter? So this was kind of an example of one of the templates that I created. On the left is a section where you can see these are pre-selected dropdowns. Before these templates, all you had was just this category that said recommendation, and then you would have to go through and look for every single one of these kind of statements. With these pre-selected, it kind of already queues up all these standard recommendations for that kind of severity and etiology of bleeding. And then the provider is still allowed to free text or whatnot. And to bring this template up, it's the addition of one click, and as I'll show you later, it saves quite a bit of time downstream. So we collected pre and post intervention data, so before and after we implemented these templates, and we defined as a process metric what we called minimal standard report. And that included the inclusion of three main recommendations. One is some statement about disposition, second is some statement about diet, and third, some statement about medications, depending on what etiology it was. PPIs for non-variceal bleeds, octreotide antibiotics for variceal bleeds. And then we also recorded documentation of rebleed precautions and follow-up procedures. In terms of clinical care metrics, before and after the intervention, we looked at what the primary team did with medication prescriptions afterwards, and whether they were compliant with either the guidelines or the specific recommendation that was in the reports, only if that included some kind of reasonable transition to an oral regimen. We also looked at whether a upper endoscopy was ordered when indicated afterwards, and whether it was rebleeding after discharge. So through the results after template implementation, so for 9 months after we implemented templates, there were 459 upper endoscopies performed for upper GI bleeding. 82% of providers of endoscopies used templates. Overall workload was reduced, as I said, by quite a bit of time. So that was 33 clicks, meaning literally mouse clicks in the EHR, 356 free text characters, and at least 2 minutes per report if you just went through and kind of wrote it without the template and with the template. Now, templates were more likely to be used when the upper endoscopy was performed alone in the absence of colonoscopy. This is not surprising when we perform both an upper endoscopy and a colonoscopy simultaneously. Again, as I said, it's not real time. So afterwards, we are documenting both reports, and often we're thinking about the colonoscopy more so, or the next step, such as capsule endoscopy. And so these templates might be missed. In terms of the clinical care metrics, the inpatient PPI regimens or compliance was higher when there was a shorter length of hospitalization and when the patient was on the floor compared to the ICU. Discharge prescription compliance was higher when there was a fellow involved in the case, when there were longer lengths of hospitalization for some reason, and when both upper and lower endoscopy were performed. Some kind of baseline characteristics that were a little interesting, that we noticed from our study. So pre versus post intervention, after the intervention, patients were actually overall sicker, so higher ASA or American Society of Anesthesiologists classification. So they were just sicker overall. We performed fewer endoscopies after the templates were implemented. There were higher risk lesions, and we tended to see multiple concurrent lesions, so an ulcer and an AVN, or varices and an ulcer or something. One thing that may have accounted for this is pre-intervention was actually right before kind of the onset of the COVID pandemic, and post-intervention was well after that initial spike. And this is just a diagram showing how the process metrics change over time. That very top line shows just the high utilization of the templates, around 80% throughout those 9 months after intervention. That main intervention was this large, kind of thicker line in the middle, labeled A, and then there were some other iterative improvements afterwards to do with consult notes, content, etc. Overall, there was some improvements in the completion of this minimal standard report. So after intervention, the reports are more likely to include some statement about diet, about disposition, and about rebleeding. And these reports are more likely to include those 3 core characteristics of diet, disposition, and medications. Now, in terms of clinical care metrics, overall, there was a clear improvements with the clinical care metrics of medication prescriptions, as well as repeat endoscopy after their intervention. And specifically, the inpatient and discharge PPI compliance, those prescriptions significantly improved. The PPI compliance improved from 50 to 78%, discharge PPI improved from 30 to 60%, and octreotide compliance, which was fairly high already, from 75 to 93. And then on the gastroenterologist side, we were more likely to remember to try and set up that repeat endoscopy for whatever reason, for variceal surveillance or to make sure that ulcer is not cancer. And that went from 61 to 87%. So in conclusion, our project leveraged endoscopy software to standardize efficient provider documentation, resulting in improved clinical care. It required minimal implementation costs. This was kind of a function that I was able to take advantage of within our endoscopy software. It didn't require much maintenance at all, and there were high utilization rates over those 9 months afterwards. The big next step was we just submitted this manuscript for publication. That's kind of in process. And the next step after this, 2 main things. One is possibly a future pragmatic RCT of one center that uses templates, one that doesn't. And another is really what I'm most interested in is expanding this to other indications. So we do colonoscopy in the outpatient setting the most, and that's usually for surveillance or screening for cancer. And this can be a way to help improve kind of our compliance with surveillance and screening guidelines, which notoriously have not been the most consistent in multiple centers. Thank you.
Great, thanks, Dr. Yan. Yeah, so if you have any questions, please enter it into the chat. So maybe I had a question about, so it's interesting that, it looks like the use of the templates improves a lot of different processes of care. I mean, what do you think led, you also showed a decrease in the hospital length of stay. What do you think, led to that? I mean, do you think it was the medications that led to, shortening the?
I think it's a little tough to say. When I tried to look through to see kind of, we did do some kind of covariate analysis to see if there were contributing factors that kind of stuck. It's tough to do since there's so many teams, and that naturally breaks people up into several subcategories. One thing that's conceivable is that when we recommend the right PPI regimen, that won't be one thing that can hold the patient in the hospital. So, for example, the most kind of part of non-compliance PPI recommendations were usually when we didn't recommend much change, we just said use a PPI, and as a result, that patient ended up getting the IV PPI for much longer than they should have. Sometimes weeks, which it's tough to say how much that contributed to their hospitalization per se, but sometimes patients would kind of stay MPO, stay in the ICU a little longer than we would anticipate based on solely what we saw in the endoscopy. So that's certainly one contributing factor that has been seen in other studies quite a long time ago, mostly in Canada, where care is a little bit more standardized. But I think that's one possibility.
Yeah, and I guess during this time, was there a change in the in general length of stay at at the hospital?
No, I don't think there was not overall. I don't remember if I had that one in here or not. Yeah, there was no. So this is just all the patients together, and there was no huge difference in length of stay overall.
Okay. Yeah, so I mean that would argue kind of that it could be related to the intervention rather than kind of time trends. And then, I mean, can you describe the process, or how difficult, how hard was it to implement the template and then to get it into Epic? I mean, what was
So luckily I didn't have to implement into Epic, but implementation of the template was actually relatively easy. I think I got lucky with this. I didn't have to do much kind of infrastructure building on the EHR side. Provation already had this function of creation of templates, but talking to the vendor, very few institutions actually utilized this. In fact, he told me that the only group that consistently used this was, I think, the pulmonology group at Cleveland, who also uses the same software. So this infrastructure was there already. So to build these templates, it wasn't difficult. It took a little bit of time to just make some of this discrete data. So that was how I was able to see how often these templates were used. I would create kind of this discrete data point where I could just, query that and see whether the template used one of these whether the report used one of these templates or not. I think one of the harder parts is more implementation of, as always, of whether end users will utilize this template. I think overall it was relatively successful. I suspected if I looked at this now longer, there will be a drop off in utilization. But the hope is that, part of this intervention was we actually incorporated this into the orientation for first year fellows who are, account for 80% of these cases, of these reports or something. And it will become just more like a standardized practice. And again, once, you get over this hurdle, even, the laggards or the people who aren't really, excited about using this, once you use these templates, overall it saved time. You added one click to select this template, and then you saved whatever it was, 30 something clicks, basically selecting all of those components of diet, disposition, etc.
So I don't see any additional questions. So I wanted to thank you for really interesting talks, and I hope everyone has a good rest of their afternoon. Thank you so much
for having us.
Thanks for having us.